I'm Yago Nieto. I'm an attending physician at the Department of Stem Cell Transplant and Cellular Therapy at MD Anderson. Um, so the study that we conducted was a phase 1 clinical trial of AFM13 precomplexed cord blood derived NK cells for patients with CD30 positive double refractory lymphomas, double refractory to rituximab vedotin and checkpoint inhibitors. So the rationale for the study was based on the preclinical data showing that the combination of AFM13, which is a bispecific antibody construct targeting CD30 on the lymphoma cells and CD16A on the NK cells, was able to effectively kill CD30 positive malignant cells. So the NK cells were derived from our cord blood bank at MD Anderson, and they were pre-activated with cytokines and expanded in the presence of universal antigen-presenting cells for about 2 weeks, and then incubated with AFM13 prior to infusion to the patient. The days preceding the infusion of AFM13 NK cells, patients received lymphodepleting chemotherapy with fludarabine and cyclophosphamide with the dual purpose of immunosuppressing the patient and also raising the production of IL-15 by a mechanism of peripheral homeostasis. So in this clinical trial, we escalated the dose of the NK cells from 10 to the 6 per kilo to 10 to the 8 per kilo, which was established as the recommended phase 2 dose without any dose-limiting toxicity identified. Specifically, we did not see any cytokine release syndrome, any evidence of ICANS or graft-versus-host disease, despite the cord blood units being heavily mismatched with the patient. And this is consistent with prior observations from our group and others. We started by treating the first 19 patients with 2 cycles of AFM13 and NK cells. Both cycles for each patient were given at the same dose, and they were both preceded by flu-cy. The last 23 patients received a plan of 4 cycles of this therapy. We saw the treatment was very well tolerated. Like I said, there were no dose-limiting toxicities. The response rate in this heavily pretreated population was in excess of 90%, with around 66% complete remissions. I want to point out that the patients had been exposed to a median of 7 prior lines of therapy. They were all in progression immediately prior to enrollment, and no bridging therapy was given between the last line of therapy and the study treatment. So at a median follow-up of 2 years, around 26% remain free of progression, with 6 patients having received a consolidation stem cell transplant following a complete remission to study treatment, and 5 patients remaining in complete remission without any further treatment.